representation in the community, but also talking about some of the things that endometriosis impacts and why we have some of the barriers, as well as providing additional information on endometriosis foods and things of that nature. So again, I am Lauren Cornegay, and this is Endo Black Incorporated. Mm. So let's talk endo, the need for representation in the endometriosis community. So, endometriosis, and you can move to the next slide, please. Endometriosis, we'll be talking about what is endometriosis, the historical context of endometriosis, racial implications today, and resources for learning more. So the definition for those who do not know, endometriosis is defined as a systemic inflammatory disease. This is something that is very near and dear to my heart. I will also share that I was diagnosed with endometriosis on March the 18th, 2011. And unfortunately, I ended up back in the hospital of that same year in August with a cyst rupture, which left about 2 gallons of blood in my abdomen. And at that moment, I knew that I wanted to change something. My mother always taught me that if there is a void, you fill it. And if you're going to complain about something, you need to do something about it. So this is the definition of endometriosis. And as you see in this diagram, it talks about all of the places endometriosis has been documented, to include the brain, eyelid, sciatic nerve, bowels, lungs, diaphragm, vulva, and so many other places. But for a long time, and still currently, endometriosis is being considered to be a disease of the womb. When in fact it is a full body disorder. And if we choose to look at it as a full body disorder, we will probably get more answers. Next slide, please. So, before we move forward further, I wanted to provide this here, endometriosis symptoms. A lot of times we don't even know that we have endometriosis. There are a lot of people that deal with some of these symptoms, and not even attribute this to endometriosis. They just think that, oh, this is just how it's supposed to be. This is how cycles are. And in fact, that's actually not the case. A lot of times there's misinformation and, of course, miseducation. And sometimes we just don't know. Specifically in the Black community, we sometimes tend to think that this is just something we have to deal with, right? Because we're strong women, and menstrual period is supposed to be painful, when in actuality is really not supposed to be as painful it is for some people. So if you have the ability to, I suggest scanning this QR code. It will take you to endometriosis symptom tracker, just in case you may be dealing with something, or may someone you know has some issues or possible symptoms. As you see on the screen, you have lower back abdomen pain, difficulty conceiving, occasional heavy menstrual periods, diarrhea, constipation, vomiting or nausea, increased discomfort. And honestly, there are a lot of other possible symptoms, such as brain fog, allergies, lower back pain, chest pains. And when I was diagnosed with endometriosis, I was thankful to have a OBGYN who asked me the correct question. She said, "Could you please describe your period?" And I did. I said, "My left knee hurt before my period, my right knee hurt after my period. I have chest pains, I have lower back pains, I have sharp pains in my back." I gave her a full description of how I felt. And with doing that, she immediately said, "None of that is normal." And a lot of times people say, "Oh, no, you're fine." If you are able to be very descriptive with your pain and your symptoms, and to pinpoint what exactly is happening, it is really beneficial to make sure you're able to communicate with your doctor. So that's why we developed the endometriosis symptom tracker. And you can move to the next slide, please. Okay, so endo in detail, and I also do understand that we have doctors on a call, so I don't want to touch on this too much because they are the doctors and they are the experts. If need, they can go into further detail about this, but there are types of endometriosis. And again, we look at endometriosis as a disorder of the womb, but never understanding that there's different types. We just hear it and we just go with it. But there's digestive, urinary, reproductive, and thoracic. There are also different stages. And a lot of times people think that the stages are based on the amount of pain you are in. And that is also not accurate. The American Society of Reproductive Medicine classifies endometriosis in these different stages and provides that information. Mm, yes. So we have proper diagnosing. And again, our doctors can talk more about this, but there is ablation and there is incision surgery. I was diagnosed with the laparoscopic surgery. That was the only way I was able to get diagnosed. That's what ACOG has recommended as the golden rule and the golden standard. There are other ways of getting diagnosed, but that's just not something that we're doing in America at this moment. There are some other things and recommendations that I have, but I want to be mindful. The ACOG has not specifically said any other way of getting diagnosed. So when you are getting information from your doctors and you're trying to get accurate information, get accurate diagnosing, these are the two surgeries that people look at. I will also say that if the surgery is being done, I do recommend that it is done by someone who is an endo specialist and someone who knows about endometriosis and how to properly diagnose someone versus just the OBGYN who may not have a specialty of endometriosis. Unfortunately, it may do more harm than good if someone who, for instance, has a focus on fibroids is not educated on endometriosis enough, and they may do something that may be harmful later on. Next slide. Here's a little bit of history of endometriosis. You would think that we knew more about endometriosis since it was earliest discovery was 1690, but unfortunately that is not the case. It has been documented prior to the actual name of endometriosis. Carl von, unfortunately I cannot pronounce that last name correctly, but he discovered and defined it as the endometrium outside of the uterine cavity. Dr. John Sampson also further talked about it and gave it the name endometriosis based off of what he believed as inside uterus and osis. And then you also have Dr. Joseph, who was the director of gynecology, who was a professor, reported that endo occurred frequently among his private patients versus public hospital board patients. Why is this important? This actually is really, really important because this is where we see that there becomes a shift. Unfortunately, after Dr. Joseph reported this information, um, several doctors, the medical industry, everyone believed that that meant that this was something that was common among white women only. So much that even in 2020, white women was listed as a risk factor on several prominent hospitals at that, websites under endometriosis risk factors. So it's really, really important to understand that private patient versus public hospital ward patient did not technically mean white patient, but unfortunately, that is how society and the medical industry move forward with that. Next slide. And because of that, we are in a situation where it was considered to be a white woman's disease. This is something that may still even happen today. A lot of people talk about their personal experiences with this. What that looks like is going to a doctor, OBGYN, telling them your concerns and being dismissed and telling them, oh, Black women don't have endometriosis. That's a white woman's disorder. You may have fibroids because fibroids is something that Black women have, but that's not the only thing we deal with. So because of, again, the private patient was synonymous to being white and middle or upper class, this led to the belief that endo was rare among non-white women. And we just see that that is not accurate at all. And it talks about how it is obvious from these studies that endometriosis is a disease of white women in the higher economic bracket. This was from Charles Hayden. And again, this is something that they decided was fact, and this is not actually fact. As we know, there were not a lot of Black women who were middle class back then. There were not a lot of Black women who actually even have insurance. The jobs that they did not allow them to have that insurance. And also, we know that our community did not trust medicine back then. So we probably did not go to the doctors as much as we probably should have. Next slide. And this is my favorite part because we have Dr. Donald Chapman, who was an African American gynecologist in Chicago. He really shifted a lot of things and actually made it so that people understood that this is not a white woman's disease. He was our first advocate. And unfortunately, he passed away, I would say, in the 90s, 94, I would say. But this is something that was really important for him. He actually did a study. And in his study, he was able to reveal that 40% of the Black private patients with surgically confirmed endometriosis were inappropriately diagnosed with pelvic inflammatory disease. Um, Gaslit, not listened to, um, you know, uh, just misinformation all around. And we know that misinformation is very, very detrimental in general, but especially to our community. And for you to insinuate that this is the issue that we have, when in actuality we have endometriosis and women could have been helped. So it's just really, really important to understand that research is critical, research is needed, but also that Chapman was someone who was a true advocate for the endometriosis community, specifically for Black women. And now we can move on. We have the NAACP President Derek Johnson, systems and structures that are procedures or processes that disadvantage African Americans is what systemic racism is. And that's something that we deal with a lot. And I know that we all have an understanding of it, especially after the pandemic. We have a clear understanding of how that truly, truly impacts our community and what disparities truly look like if we did not know that before. How many of you, I don't know if everybody can put it in the chat, how many of you have heard of Mammy and Kenneth Clark? Anyone? You can all put it in the chat or make a reaction with a thumbs up or a heart if you have heard of them. They actually worked on the 1947 Black Doll experiment. This was something that was near and dear to their heart. A duo couple, husband and wife, um, who came out of Howard University, discussing how important it is for Black kids to see Black kids because representation matters. This study went on to do amazing things, improve so many different things that it also was used in the board of education case for Ruby. You can move to the next slide. And it further just talks about how it was a really important study and how it exposed several children's experience to internalized racism and why representation matters in the first place. If you do not see yourself, you do not see yourself in that situation. And it's truly, truly important. And we may think of it as something small, but if you've never seen a Black doctor, you may never think that you could become a Black doctor. If you've never seen a Black person who suffers from a specific disease or disorder, you may never think that that was something that we could experience. And if anyone remembers, I remember what people thought for a long time during COVID that Black people could not get COVID. And for some reason, that just ran through our community. And then next thing you know, we had a lot of disparities. And unfortunately, a lot of people died because of that. Next slide. This right here is just uh, uh, a basic view of what that study looked like, the choices of the African American children who participated in the study, and how it truly, truly impacted the children. It talked about how the choices of the African American children in 1939, the Black doll versus the white doll versus Do Not Know, they actually talked about how Black children looked at Black dolls and how they thought it was a bad doll, or would they play with this doll? Was this a nice doll? Like understanding that how representation is key, but also visually seeing yourself and not seeing yourselves puts you in a situation to not understand the correlation that you may have. Next slide. All right. So, what does that look like for us now, and how does this affect Black women? Um, we talked about this a little bit earlier today. I attended a conference. It was the Policy for the People, hosted by the Congressional Black Caucus, and we talked about how the American Medical Association had some individuals that worked directly with them that were specifically racist, who just did not. Just did not care for Black people at all, right? And unfortunately, we don't understand all the time, but there is always a correlation to leadership in an organization, and that trickles down. So in 2016, the Association of American Medical Colleges reported that half of the white medical trainees believe Black people had thicker skin or less nerve endings than white people. Why would you think that? You will only think that if that was something that was taught moving down further and further. And I'll share this. This is not actually on the slide, but there's a um, I'm not calling him a doctor, but his name is J. Marion Sims, James Marion Sims, who was born in Heat Springs, South Carolina, who ended up growing up to be listed as the father of modern day gynecology. We do not recognize him as that anymore. He operated on enslaved Black people. He did not use anesthesia. He went on to become the president of the American Medical Association in the 1800s. Looking at those correlations from the 1800s to, I guess, the 1900s, sounds so crazy to say that, to the 1900s to 2016, and understanding that there is a clear correlation between that. And unfortunately, the teachings and the practices of individuals for 1800 still are causing issues to this day. You can talk about racism, you can bring up the awareness, you can talk about all of these things. However, if you don't change the books, if you don't change the research books, if you don't change the research subjects or individuals who participate in research, you're never going to get to a place where you understand that Black people or brown or Black people are not some just type of individual that is so mysterious and different. Everybody bleeds blood, right? Everybody has red blood, and everybody deserves proper care. So we need to really do away with all of the negative and the harmful rhetoric that's out there. And yes, it's really great that at some point, during COVID, after COVID, there was a uproar where people took down statues and threw paint on statues, and all of that was really, really great. But it was not enough to continue that to allow people to say, we're going to change medical textbooks. If we don't change those medical textbooks, if we don't start working with community organizations, patient-led organizations, we're not going to be able to get to a better place. You also see that 29% of hospitals treated portions of Black patients that was comparable to or higher than portions of Black residents in the community. You also talk about how JAMA Internal Medicine reported that Black and brown individuals have a longer wait period in the emergency rooms as well. So there's always going to be a barrier, or there's always going to be something that is a disparity for Black people if we do not change or rectify the issues. Okay, so challenges that Indo Black tackles. As you can see, Black women constantly are misdiagnosed because they're not even telling us from the very beginning that we possibly have endometriosis. There's a lack of resources and there's a lack of research. We talked about how medical bias and racial disparities leads to a delayed diagnosis of often 8 to 10 years. And unfortunately, there's already a delay of diagnosing for endometriosis, but the delay actually increases for Black women. And then endometriosis is what we're learning is a leading cause for hysterectomies among Black women. And At some point they talk about how hysterectomies are actually a cure for Black women. What I will say about that is what may work for one person does not work for everyone. I know people that have had hysterectomies, partial hysterectomies, taken holistic approaches, use birth control. So it's really just depends. But if Black women are being pushed to have hysterectomies without looking at all of the options, and all of the possible outcomes or opportunities that they may have to be healthier, it is very detrimental to Black women, and it's just not fair. Here is a photo of myself and Nakima Williams, Congresswoman Nakima Williams, um, Shannon Conan from what we also have Society Women's Health Research and Endometriosis Foundation of America, where we were at Capitol Hill trying to advocate for the Endometriosis Care Act that was actually pushed and created by Representative Dr. Lauren Underwood and Representative Alma Adams. It is looking at doing $250 million in research, and that would include Black people. I'm not sure where that's going as of right now, according to the administration, but that doesn't mean that the fight ends. I hope that all of you all take a moment to just do some research on that. Next slide. Okay, so changing the narrative. Previously, I mentioned that in 2020, we had a lot of organizations, hospitals, prominent hospitals stating that being a white woman was a risk factor of endometriosis. So changing that narrative is very, very crucial. And what myself, as well as other women, decided to do was work together, and we sent emails out directly to those hospitals, specifically doctors at those hospitals. What we learned is really important, that a lot of hospitals, doctors do not work on the website. Doctors are doctors, they're not webmasters. So just making sure that the doctors know what's on the website and what's being shared and communicating that. But they were very appreciative of us actually reaching out and informing them. So it's really important to understand that you all have a voice. And sometimes people do not know and recognize the error in their ways, especially if they're not informed about it. So just understand that you all have a voice, and it's really, really important that we utilize our voices. All right, so the many faces of endometriosis. I'm sure that you all may be familiar with some of these women. You have Tia Mori, who actually was my inspiration for starting my nonprofit organization solely because she was the only one at the time that was talking about endometriosis. When I was diagnosed in 2011, I didn't know how to pronounce it. I didn't know how to spell it correctly. I was simply confused by it. And though my doctor diagnosed me with it, there was no real call to action. There was no plan. There was no treatment plan. She just diagnosed me, and then that was pretty much it. So just trying to do more research, I ended up stumbling upon Tia Mori, and she was somebody that inspired me. You also have Monica's here. She's talked a lot about it. Chrisette Michelle, Rosaria Dawson, Jamie Foxx's daughter, Corey Smith. You also have Eve, who recently wrote a book about her experience with endometriosis and giving birth and all of that. So it is great that we have Black representation. They talk about it, but it needs to happen more, and we all should be doing our part, even if we don't um, have endometriosis. For those who don't, it is a reproductive health disorder that impacts several women, and I'm sure that you may know someone that has endometriosis and you may not even know. So just talking about it amongst ourselves, amongst our families, is really, really crucial, and is really, really important. Next slide. We also have some endo foods. And I do want to say again that what works for one person does not work for everyone. One of the things that I had to do in my journey of endometriosis was really just figure these things out, what worked for me. And at the time, I was shifting. You know, as you get older, your body just changes naturally. In 2000 and what year was that? In 2000 and I think 15, 16, I relocated to South Carolina. As I lived in that location, I started to develop an allergy. And I wasn't really sure what the issue was because I was perfectly fine with eating lemons and limes and mangoes and oranges prior to, but I developed an intense allergy to anything that was a fruit that was yellow, orange, or bright pink, like grapefruit. And I could not understand what the issue really was. So I had to change my diet. And it took me a while to figure it out. I kept getting lemonades from Chick-fil-A and my throat kept itching, but everybody loves Chick-fil-A. So it was difficult for me to not recognize that that was what was the issue. Also, milk, cheese. I love macaroni and cheese. I'm not going to lie. That is one of my favorite dishes. But since 2023, I've actually taken that out of my diet, which is very shocking to myself. Thanksgiving, Christmas, I refuse to eat macaroni and cheese like I normally would. And it just doesn't do good for me. But again, everything works differently for other people. Finding substitutes. I have a friend, she decided to figure out how to somehow make macaroni and cheese with um, vegan cheese and cashew milk. I didn't like it. I didn't like it at all. So we just took it out my diet completely. Sometimes you just can't make it. You can't fake macaroni and cheese at all. But other things that I gravitated to, I realized that corn was something that inflamed me a lot. But tea, raspberry tea. Looking at those things, certain cabbages, purple cabbage didn't do good for me, but regular cabbage was perfectly fine. So I changed and I adjusted the way I ate. Also, I'm sharing some anti-inflammatory endometriosis guide and then nutrition and lifestyle guide for endometriosis management. I have a team of individuals are a part of our ambassadors program. One of them is a nutritionist. She focused on really just making sure we have these things that are available to our community. A lot of times we tell people, eat healthier, do this. How? How? So we want to make sure we provide those guides for you. Another thing, a lot of times people say be vegan. This is how you should do it, or be a vegetarian. Being a vegan or vegetarian does not work for me specifically because I recognize that soy is based off estrogen. So if you are eating slutty vegan, for example, that is a burger with it, a black bean burger. Black beans have soy, which has estrogen. So for me, that would inflame me. But for others, that might work. But it's just really important to understand what you may be um, dealing with, what foods are causing. And that honestly is not just for endometriosis, but it is for everything. Track the information, understand that your body does change. Next slide. And then we have tips. As I mentioned, track that information for your diet, but also track how you feel. Track those things. For those who have notepads on their cell phone, my cell phone is my handy dandy notebook. I go straight to my notepad and I actually have a list of medical history, not just about me, but also including my family history. So anytime I'm at the doctor's office, if I have a question about something, I pull that out. Something that I also paid attention to was if I am in pain, how long is my pain? What happens when I eat this food? Do do I have a flare up instantly? Do I have a flare up an hour later? Is it a 10-minute flare up? Is it a 30-second flare up? Because these are things that you want to tell your doctor, right? You want to give them as much information as possible because this helps them decide on what to do, how to help, what are the suggestions, or what the diagnosis possibly is. Also, looking into yoga, I'm not gonna lie, I don't do yoga. I might stretch though, and I do walk, but I don't do yoga. Again, do what makes sense for you. You also have CBD gummies or CBD lotion. That's for the pain. If your body is aching, if you need something to release that, that is something that you can definitely look into. And then looking into healthy, holistic approaches just to have better health in general. Um, Food is medicine, and we know this. This is something that should be understood across the board, but unfortunately, food access is the real issue. Food deserts are the real issue. So just trying to understand how to navigate what recipes to do, and doing that has been very beneficial for me. So I can recommend that you all do the same. Next slide. And also, if you're trying to learn more about endometriosis, more about medical bondage, medical apartheid, anything to do with medical things that have happened in history, please take a moment to look at some of these books. We also have a QR code. We recommend some book recommendations. It's about 3 pages long. So definitely scan that QR code. Here's a book on Henrietta Lacks, The Untold Story. There was a book that came out by Rebecca Scott. Unfortunately, that book depicted them as a family that was a Black poor family, and that's just not the case. So her grandson actually came out with the book, and I want to make sure that I share that with you all. We also have the Medical Apartheid, which is one of my favorite books because in it, it talks about all of the things that have happened to Black and Brown people in the United States and how things correlate, right? We don't understand, as I mentioned previously, how things from the 1800s typically correlate. And it's really good to like put those two things together. Part of you, not all of you, this book is written by a friend of mine. She has endometriosis, and unfortunately, she also has lupus. But this is a really great book. She is someone that has her own nonprofit that focuses on endometriosis called Endo Coalition. And then we have some additional books that talk about endometriosis, but also menstrual cycles and reproductive health in general. So I do recommend that you all take a moment to look into these books because I think they will be very, very beneficial. And then we have some resources. If you want, you can screenshot. You can actually take a moment to uh, take a picture of this to look these up. We also have Samantha Dene, Kyla Kinzada, April Christina. April Christina actually lives in New York. She's an endometriosis advocate. She's also an infertility advocate. So these are really great people to connect with. You also have some organizations that are really, really doing the work behind the scenes. There is a Below the Belt documentary. You should check that out definitely because it actually follows 4 women, including Jenna, who wrote the book, about their experiences with endometriosis and how they navigated it. It talked about women in America and I think another woman who was in Canada. So it's really, really good to see that. And again, these are just amazing organizations and advocates that you should definitely check out if you feel like you are dealing with infertility, endometriosis, and you never know, it may direct you to more information about other reproductive health situations. Next slide. And then lastly, Sorrento, one of the things that I really, really love about the work that I do is I have an opportunity to connect with other institutions and organizations. And I have been honored and blessed to be able to work with George Mason University. This will be our third research study that we've conducted. This research study actually focuses on teenagers, teenagers and young adults ages 13 to 25 years of age. The idea is that individuals will play this video game and learn about endometriosis. Right now, we are in the early pilot of it. If you know anyone who is Black or brown, who is dealing with period pain, not necessarily endometriosis, but they're struggling, please, 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 I ask that you share this. I know research is not something that we always gravitate to, but it is very, very difficult to do research. It's very difficult to help and change the narrative if we don't have the data or the numbers. One of the things that I learned from the NIH director is to don't do research without me about me, right? So I'm just glad that I was a part of this. As you see, these are brown and Black individuals. The main character is Afro Latina. She has her friend who is Black and then her other friend who is Latina. So we had young adults. We call them the YAC. Unfortunately, that is not a pretty name, but it is Young Adults Committee. They focused on really just providing us additional information and ensuring that we have all of these stats, experiences, so that we can create this game specifically for teenagers. A lot of times we talk about adults, but if we are able to help teenagers who become adults and prevent situations, we are going to be able to do so much more. So that is about it. Thank you so much for listening to my presentation.
Thank you so much, Lauren. Thank you for sharing your story. Thank you for that powerful and eye-opening discussion, which is going to lead us now into our Q&A session. So we're excited to shift into our live panel Q&A with two phenomenal physicians who bring both expertise, compassion to the forefront of women's health. So please join me in welcoming again Dr. Tendai Chawawe, who is a reproductive endocrinologist and infertility specialist at Genesis Fertility, and Dr. Christina Pardo, OBGYN and director of the Women's Health Practice. We invite you all to drop your questions in the chat as we dive deeper into this subject, talking about diagnosis, treatment, equity in care, and lived experience for those navigating endometriosis and reproductive health challenges. So we do have some questions that were submitted to us when you registered. You had the opportunity to submit your questions. So we'll go through those questions first, and then we'll take any questions that are in the chat. All right. So please feel free to drop your questions in the chat, and we'll be sure to get to them after we go through our questions that were submitted prior. All right. So this can be to either one of you, Doctors Chaware or Pardo. You can decide who wants to take which question. So the first question that we have here is, how can we get more research that prioritizes wellness and preventative health education regarding endometriosis?
Well, I think I can start first. I want to thank the entire organizing committee for pulling this together and bringing all of us here together to share information. And I want to acknowledge really the great presentation by Lauren. First, for our advocacy, it was a great presentation. I really thought it was on point and balanced. And so I really appreciate that for both sides of the spectrum that I live on, the clinical care and obviously the community aspect. Um, at the high level regarding advocacy, it really starts with all of you, so as soon as you start to, ring the alarm and put pressure to ensure there's dedicated funding towards this, that is the what really helps to move things forward, that helped to move things forward of maternal mortality, which always existed, but as soon as the community started really advocating about this, that's when more dedicated funding started. So I would, raising the alarm in the advocacy at all levels, even local. So the city council level, the institutions that you work with, because there are different types of grants that are available. So not just government, but foundations and different things. So, keep putting the pressure and looking for many different options, governmental and non-governmental for options for support.
Thank you. Dr. Chawari, did you want to add anything to that?
Yes, thank you. I agree completely with Dr. Pardo. And I would also say that speaking to your doctors about it, because educating your doctors about something that this is of concern for you is vital too. And that also helps in terms of the trickle effect of actually training the medical students and the residents, so that when they're actually in their practice, they can understand the difficulties that we face in the diagnosis.
Thank you for that. So our next question is, does genetics play a role in a woman's fertility? And what is the one advice that you would give regarding reproductive health?
I'll pass that to Dr. Chua.
Genetics does play some role, yes. In regards to endometriosis, about 25% of women who have endometriosis, there is a genetic component. So 25% of them, their mothers, sisters, aunts, other female relatives will also have suffered from endometriosis. So there definitely is a component to that for sure.
Well, that's good to know. So if there was one thing or one thing that you'd want to share regarding or advice that you'd want to give to a young woman regarding their reproductive health, what would that be? Either one of you can take that question.
I'll start by saying that you know, uh, reproductive health is a mixture of many things, right? Science and physiology, and also our bodies and personal, and obviously there's a genetics and all those things. So expressing what you are experiencing, and not being fearful to do so. And if you feel like you're talking to somebody that is not responding to you, then being comfortable going for second opinion. And two, recognizing, like I said, it's a mix of many things. So the biology, the environment, the pathophysiology, what you're in maybe doing or not doing personally. And so with that, because it's many of these puzzle pieces, is that sometimes we don't have like a clear path that we can say this is what's going on and this is how we can solve it. Some things is very clear. So if there's a test and we have a diagnosis and then we can treat it. And so reproductive health is not always so clear cut. So it really does require your partnership as a patient with the provider so we can navigate through that step by step. And so it does require understanding and experience and humility from the provider, and also the willingness and openness and sometimes patience from the patient. As sometimes things like, for example, like endometriosis, PCOS at times are not always black and white. And
Mm.
and we are often working in partnership to solve those. So speak up, let's know your body, advocate, and obviously remain in communication with your provider, but understand that sometimes it's not a clear path, and we really have to work in partnership to help to solve the problem.
Thank you. So know your body, advocate, speak up.
Yeah.
Got that. Um, so are sonograms necessary, valuable at every annual visit to your OBGYN?
I I'll start with that. Thanks, Joyce. I know I this is a common, I'm happy to be a general obstetrician gynecologist because I love to be on the spectrum of all things OBGYN. And so, and I do my annual exams, and this is a question that comes often about do we need a pelvic ultrasound? So from a medical and healthcare perspective, it is not needed at every annual visit. So if there is something based on what is said, if we detect something on exam, then yes, that we could. But an exam that's done thoroughly, that doesn't detect certain things like an enlarged uterus and there's no pain, it does have a low yield to do that ultrasound. Having said that, I do understand some patients where they've had in the past, and so I do not. If a patient says, I had ultrasound last year and it showed up, and I would like, I will do it. I will let them know that it's not indicated at this time. Everything was normal. There are no, but trying to be really patient centered and understanding kind of the personal anxiety and thought process. I will go ahead and, and do that, but it is not recommended or needed as like routine annually.
Okay, good to know. Can you describe the effect on menopause, or it says, can you describe the effect on menopause and endometriosis, if any?
So I can take this one, Dr. Pardo. So essentially, when you're thinking about endometriosis, endometriosis feeds off estrogen, and you're producing estrogen continuously during your cycle. when you're having your periods and the cycle throughout. So when you go into menopause, your estrogen levels actually drop because you're no longer producing follicles with eggs in them, and that's what essentially produces the estrogen. So in menopause, endometriosis, actually the symptoms will improve, and we sometimes find that the cysts that may have come across because of endometriosis, like endometriomas, those are the cysts in the ovaries, these sometimes will shrink. And any endometriosis that may be in the muscle of the uterus that cause painful and heavy periods, those implants also shrink as well. So there's less pain.
Okay. I'm sure that's for anyone that's maybe suffering with endometriosis, that might give them some hope as to, when the time comes that it'll be less symptoms and less symptomatic for them. All right, thank you. All right, so why would women, particularly Caucasian women, vote against their own interests when it comes to reproductive health?
Oh, well, that's quite low. I need an example.
That was the question that was given. I'm not sure if
Uh,
that person is on the call that wants to expand more on the question. Let me see if anyone says anything additionally in the chat.
That was me. Erica Isabel.
Okay. You
That
want to
was
expand on
me.
that question?
Um, I don't know. I guess, I'm just wondering as far as like, with reproductive health and endometriosis. I mean, is endometriosis more prevalent? I'm sorry if you might have said this and I might have missed it, but is endometriosis like more prevalent in the Black community? Would that be more of a reason? Would anyone know if that might be more of a reason why they might have, not have seen that as a priority to vote, you know, for their interests rather than against?
what was the vote like? I guess what was the specific, I guess, vote? Like what was it the bill, I guess, that was shown in the presentation? I mean, I'm just
I think my issue is the fact that, when people voted, right, a lot of times what they did was they voted um, as far as we're talking the past presidential election. They voted for one person over the other. We don't have to say the name because I don't like saying his name. But the fact is that they voted for that person knowing that that person pretty much gave autonomy to the governors of each state to make a decision on how to handle reproductive health. And unfortunately, in states like Texas and Louisiana, a lot of our Black women of color are suffering the greatest, more so than our Caucasian women. And I was just wondering why they, I mean, we all have vaginas, we all have, we all have these reproductive systems. I'm just trying to get a little deeper as to why they would vote against that interest. Would it be because of the fact that a lot of our concerns are not their concerns as much? Or they just maybe voted the way their husbands voted?
I mean, I would
Just a
say
thought.
generally, like I mean, to start the endometriosis, as somebody who's practiced general surgery and gynecology, it is something that really, cuts across. So there are patients like all racial, socioeconomic backgrounds that have endometriosis. So just to share that, and I think, I mean, from the larger issue, I think in general, I mean, we can't speak for each individual, but I do think people vote for their interests and what are maybe the highest priorities in that moment. So if they felt for financial reasons this was a better vote, if they felt that they have, let's, if we use endometriosis as an example, if they have the care or the access or whatever that they need, and so they feel they may not be impacted by certain things, or or not a realization of how they might be impacted. So, I think it's a hard topic, a hard question, and I think ultimately, when people went in the voting booth, they vote on whatever was their highest priority, and that includes, people that are Black, African American, Hispanic, who also, voted that way based on whatever they felt was their highest priority interest.
I agree
Thank
with that.
you. Thank you.
Dr.
I,
Chawara?
yeah, I just want to mention as well, being in the fertility world, it became very obvious towards the end that there were different agendas, and I believe that a lot of people voted to gain more access to fertility treatments. Whether that's going to happen in the current administration's term is yet to be decided. But in terms of a lot of people who I've spoken to who are my patients, that's where their vote lay because of the promises that were made to improve access to fertility care.
Okay, thank you. Thank you so much.
Thank you.
Thank you. And I believe also Lauren had answered, it goes back to representation matters. I know on the advocacy side of things. I don't know, Lauren, if you wanted to expand more on that. But
Yes, I can. I was saying it goes back to representation matters because what we may see as a situation or struggle that we've gone through, we see our moms, our sisters, we hear the stories about reproductive health, and if that is not an experience of another person, whether it's a different race or someone who lives in a different demographic for us, what people in the South go through isn't always what people in Maryland and Philadelphia or even in New York go through, right? So our experiences are completely different. And sometimes um, when you don't have, I don't want to say when you're not cultured, but when you don't have exposure to these things and you live in a predominantly red state that's docked off the side, you don't know what's going on. Now, would you care? Who really knows if they did know what was going on with people that were struggling in the South, if they even would care, but because that is not something that impacts them directly. And I think you mentioned it. If it does not impact them directly, they're not going to see it as a problem. We see this all the time with gun violence. When they talk about stop the violence or gun violence movements, people don't talk about it until it happens directly in their backyard. And now they become advocates and now they want to talk about it and get the word out. But if it doesn't happen to me directly, unfortunately, I may not even talk about it. So that's unfortunate that that has happened, but we see it time and time again. And that's why I say our voices truly, truly do matter, because though you may not have endometriosis or fibroids or adenomyosis, you may know someone that does, and they may not even know they have it, right? The more education we have, I can vote based off of my experience, but also the experiences of Black men that I know, because I have people in my family that are Black men. I know their stories. So now I vote in that interest. And it's just unfortunate that everybody doesn't have that opportunity or the the wherewithal or the care to do that.
thank you, Lauren. And we have a couple of questions in the chat. Just want to pivot here on the chat questionnaire. um, we have from, let's see, Jessica Tucker. If you have had fibroids in the past, does it put you at greater risk for endometriosis? Either doctor.
So they're two separate disorders. Fibroids are usually overgrowth of the muscle of the uterus, and it becomes hardened, and that's what causes the fibroids to form. Endometriosis is where the inside lining, as Lauren said, the endometrium is actually in the wrong place. So it's in the muscle of the uterus, or it's outside in the pelvis. So every time you're bleeding and having your period, you're actually bleeding internally in the muscle of the uterus or into the pelvis. So they're two separate disorders. So no, one doesn't put you at risk of the other.
Dr. Pardo, did you want to add to that or anything?
No, I agree with that. And certainly some people may have both or overlap, but there isn't like a straight line risk factor from one to the other.
Awesome. And our next question, Andrea, how has the treatment for endometriosis changed over the last 20 years? I was diagnosed 25 years ago. Have treatment and management improved?
So I think that I have seen and I'm not a endometriosis specialist per se, usually in general, such in gynecology, we will start with the baseline evaluation, the symptoms, and starting what is usually the kind of presumptive management. One, like Lauren did a great presentation, and it is accurate that laparoscopy is the gold standard. However, if the symptoms are consistent and that's what you're suspecting, you can medically presumptively manage, because sometimes it's best to not do a surgery right away. Surgery has risk. And so if you're able to medically manage it without needing that going to that surgery, that's always a good option depending on the circumstance. So in our role, we typically will do that, which does include type of anti-inflammatory and hormonal management. Um, Hormonal management, because again, because it's the lining of the uterus, that the endometrium. The endometrium is responsive to the hormones, and so hormonal management is an important medical aspect to counteract that. So what I have seen that's come over time where that additional options that may not be the typical, like birth control pills. I don't like to say birth control pills, but combined hormonal medication, where it's not just that, there are other alternatives that play a role in mitigating how our hormones impact the endometrium. And I have seen it start to be more um, specialty approach, where including like pain management, including some type of pain management medications, not outside of the anti-inflammatory. So I do see that it is taking a little bit more of a comprehensive approach to try to medically manage endometriosis to prevent or in replacement of like a surgical management.
Thank you.
Can I add something to that also?
Mhm.
And please
Absolutely.
correct me if I'm wrong, but there has been some studies and additional information about diagnosing individuals non-invasively. So looking at like MRIs, looking at pelvic exam, ultrasound, sonograms. Other people have been diagnosed and other things, not saying that this is something that should be done or anything, but I just wanted to share that that wasn't even offered to me in 2011. So I feel like there's more conversation about it. The Mayo Clinic also has talked about this before. They actually hosted a conference that spoke specifically to endometriosis about diagnosing via MRIs. So that is something that has changed.
Yes, certainly. I do diagnose a lot of endometriosis where I work, based on ultrasound, MRI, as you said, Lauren, as well. There've been a lot of advances in the technology, so we are able to see, as Dr. Pardo mentioned, endometriomas and cysts on the ovaries, which then, we then presume there is that diagnosis. We're able to diagnose adenomyosis as well in the uterus, which is endometriosis in the muscle of the uterus. And then MRI also can confirm that too without being as invasive as surgery. And then in terms of other tests that can be done, there is some testing. It's not FDA approved, but you can do BCL6 testing, which is essentially it's a receptor that's inside the endometrium itself. And if that's positive, that gives a very high probability that you do have endometriosis as well. That is an endometrial biopsy, so it is something that's a little bit more invasive than an ultrasound or an MRI, but not requiring surgery and anesthesia as well. And then in terms of advances in the treatment for endometriosis, Dr. Pardo mentioned the medical management and laparoscopy as the surgical management. There have been, again, advances in laparoscopic surgery, and now we're doing robotic surgery, which has made some big advances in being able to actually excise the endometriosis quite effectively as well.
Thank you. So I wanted to just ask a follow-up because Dr. Pardo, you mentioned a hormonal or birth control that might be prescribed along with probably other things that you will look at for that particular patient. So being on these hormonal or birth controls, do they have an effect on one's fertility down the line? How does that affect my fertility later on?
So, Dr. Chira, our infertility specialist, but I mean, I do not think that routine has an effect on the long-term fertility, but I will pass it to Dr. Chira to give the formal advice on that.
So the issue with hormonal therapy is that a lot of women are on the hormonal therapy to control the pain or the heavy bleeding that they are getting with their periods. And when they've been on it long term for more than 5 years, sometimes when they stop it to try and get pregnant, their cycle has to return back to its baseline. And that can take anywhere from up to 6 months to a year before you're actually having your regular cycle as it should be for you to be ovulating every month to try and get pregnant. So that's where then it can cause an issue. And so that's one thing to consider. As Dr. Pardo said, there are other options for hormonal therapy like IUDs, etc., which won't necessarily disrupt the function of the hormone production from the ovaries, but the regular hormone therapy that's oral may do that.
All right, thank you. Nikiba, you
Yeah.
had another question in the chat?
Yes, we had another question. How is placenta previa and accreta related to endometriosis? I know we probably touched on this a little bit earlier, but just to go into detail. Anyone?
I'm not a doctor.
Yeah, I mean, I'm not sure if I missed that in the presentation. So, I mean, I'll just speak to what placenta previa and accreta are. First, I will say that obstetrics is, something where there is a lot that we know and there's a lot that we don't know about obstetrics. But our job is to make sure everybody can have as safest of pregnancy as possible and deliver as possible. So the placenta previa is when the placenta is covering the cervix, and placenta accreta is when the placenta starts to invade kind of the wall of the uterus. Both has risk factors for hemorrhage and bleeding. Things that can impact like the placentation, the placenta over the cervix is, yes, if there are, if you have large fibers or things that are kind of distorting the uterus, then that is a potential for that placenta to stay over the cervix. For the accreta is usually the most common risk factors is if you've had procedures on your uterus. So you've had a previous myomectomy, removal of the fibroid, perhaps you've had surgery or a C-section, anything where you've made an incision, even through kind of going through surgery, if you've gone through the endometrium and then, went into the muscle layer, those are the things that will increase the risk of accreta. I do not know off the top of my head a clear association between endometriosis and placenta accreta unless it's related to surgery or something else, and I can certainly look into that. But it's usually more associated if you've had like surgeries on your uterus that you have that increased risk of placenta accreta.
Yes, absolutely. And there is a thought as well that the adenomyosis does distort the anatomy of the uterus and can cause the placenta previa. And then there is some thought that the reason why the endometriosis does migrate into the muscle of the uterus to cause adenomyosis, that may also represent why sometimes accreta can be more common and why there's an increased risk of miscarriage with endometriosis.
And though I'm not a doctor, I will share that one of the things that I want to make sure that I accomplish with the organization is talking about preconception. A lot of times we're working in silos where we talk about menstrual health here, reproductive health here, and maternal health here when they're all connected with each other. Because once we talk about menstrual health, and we see that the teenager is having difficult periods and understanding this, we now can talk about reproductive health and possibly endo fibroids, what that looks like. Once we have that proper diagnosis, we go from preconception, which is reproductive health. We start to look at that. We have conversations with OBGYNs about what our difficulties may be, and then we could prepare properly for maternal health. So just understanding that those all work hand in hand, and they are very synced together.
All right, so we'll do one more questions and then we'll close out. So the last question that we have is, um, one second. I lost it. What can I do, or what should we, or should someone consider now, to do if they're thinking about getting pregnant in the future to protect their fertility or reproductive health?
I can take this one first. So my recommendation is to speak with your healthcare provider, either your nurse practitioner, OBGYN, primary care provider, and let them know what your fertility desires are. If you are interested in getting pregnant, then they can advise you on different tests you can do. I always say know your numbers. The main number to know is something called AMH, or anti-Müllerian hormone, which is essentially released by the eggs that you're born with, and are continuously losing throughout your life, which is why women end up going into menopause. So I would say that any healthcare provider can do that test for you. Most of them are able to then counsel you on whether or not you need to see a fertility specialist, whether or not you need to freeze your eggs, what age you can freeze your eggs at, depending on what your fertility desires are. And then they can also sometimes, even though Dr. Bardo was saying that, ultrasound is not always first line in annual exams, if they suspect a fertility diagnosis, then they can further pursue that as well.
Thank you. We have one last question in the chat.
Yes. Our next question is, so it says, I know the focus today is on endometriosis. However, what advice would you give someone that was diagnosed with PCOS without all the symptoms to do during their annual appointment with their gynecologist?
I'm not sure I fully, I'm just going to restate it if I understand that correctly.
Or
Is,
unless, do you want to expand on that question? Or clarify the question?
Yeah, sure. So there are numerous symptoms, but if you don't necessarily have all the symptoms, like what do you recommend someone that was diagnosed with a mild version of PCOS to do during their annual visit with their gynecologist? Is it similar to endometriosis? Like, would you recommend a patient to follow the same steps that were discussed today? I guess that's my question.
So I will say, PCOS is also a lot similar, like many things in reproductive,
Right.
similar to endometriosis, where it's like this bucket, and sometimes it's very clear, and sometimes it's not, and then you may have something, so then you just have to decide what's the best plan. So the tenets, I think, are all accurate. There's a lot of and I see somebody put a resource there. There's a lot of resources and information, so you can kind of inform yourself and be open with, be in tune to what you're feeling, and open with your provider so you can come up with a plan. So, PCOS, not to go to just to put everybody at the same level, PCOS is usually a condition. It's actually called a complex metabolic and reproductive condition, in which there are three there's a specific criteria in which if you meet two of the three, then it formally meets that criteria. What I have, and it's usually like if you have irregular cycles, menstrual cycles, if you have polycystic ovaries on ultrasounds, and third, if there's biochemical, meaning if they do your blood test and they see evidence um, of PCOS, or like physically on presentation. So what I have found, being a gynecologist, is that not everybody will meet like specifically two of those. However, if this is suggestive of it, I still will manage them the same way. And they say, here are our options. We can start with one and see how you do. And it really does require like an individual approach and trying different things until we get to a place that works well. Or if we've exhausted those with me, then, referring to somebody else to see maybe they have additional options that they can work with the patient. So it does require really a personalized, a patient centric approach, and for the patients to really guide that, let us know what's happening. I have patients who are really very proactive, and then they tell me, no, I'm concerned about this, and and they say, I researched this and I found this, I would like to do X, Y, and Z. And we go through them. I share my opinion on those and what I think we should do, and then we go from there. And so PCOS really is like that, where it has to be personalized, and your input is really important to finding a good therapeutic space.
Yes, absolutely. I agree. And it also depends on how bad the symptoms are that you're facing and how much they're bothering your everyday life. As Lauren described, with endometriosis, there are holistic measures that you can do, holistic treatments, and also lifestyle modifications as well that may help to alleviate some of those symptoms.
All right, thank you so much. Okay, I don't think we have any other questions in the chat. So with that, we will close out our presentation for tonight. So to all our attendees, Sigma Kappa Zeta would like to extend a heartfelt thank you to all of you for attending our event this evening. Your presence, engagement, and participation were invaluable, and we look forward to seeing you at our future events. As always, we appreciate your continued support and enthusiasm. To our wonderful facilitator and panelists, thank you, thank you, thank you for your valuable expertise, engaging insights during today's discussion. Your contributions made the event a success, and it was an honor to have you, and we look forward to working with you again with a future event. So please be sure to follow us on our social media sites, z5bskz.org and at z5bskz. Nakiba will drop that in the chat, and we look forward to seeing you all at our other events. And we thank you all for attending. Thank you, Dr. Chiwari, Dr. Pardo, and Lauren, for a wonderful presentation tonight. So thank you all for attending, and have a good night.
Good night.
All right, thank you.
Good night.
Good night.
Good night. Thank you.
Thank y'all for joining. So we have Lauren. Thank you. Thanks, Whitney.
You can stop recording.